Yeah.
Hi, good evening, everyone. Welcome back to our usual Wednesday webinar. And I have here with me Dr. Yong, who was a professor in University Hospital previously and doing the transplant surgery. And recently you also went back to UH to do some transplant, right?
Yep, I did.
Yeah. So you
To
still
help lah, to help. Mhm.
so you still go back on a regular basis?
Only for transplant. The
Oh,
rest,
I
I think
see.
they are quite good at it already. So only for transplant.
Okay, so Dr. Yong has recently joined Sunway Medical Center about 9 months ago, and then currently he's also doing a robotic surgery in quite a number of his cases. And without further ado, Dr. Yong, can we maybe start?
Sorry, let me go right from the beginning. Wait, let me go right from the beginning first.
Okay, to all the nurses, please listen now, okay? The ECert registration form will be shared in Facebook only in Facebook, yeah, and look out for it. And it is not the it's not the registration form for CPD points for doctors. That one is for doctors only, okay? So please take note. So I would suggest that eventually you look for it in Facebook. Yeah?
Okay, without further ado, I think we should start. Thanks, Betty, for the invitations. And those who were in here earlier, you overheard our chat. I was Dr. Yong from UM for the past 20 over years. I just joined Sunway. I'm a HPB surgeon and I do some transplantations as well. Now only in UM, helping UM. Okay, when we're talking about HPB disease, today's topics is actually talking about pancreatic cancers and tumor management. When pancreatic cancers is one of the most aggressive cancers around, and it's almost like death sentence when you are diagnosed with a pancreatic cancers. But pancreatic cancer has many different types, and the most common is, of course, adenocarcinoma, but there's also the rarer type like adenosquamous, squamous cell, and neuroendocrine tumors. And there are also this group of cystic neoplasm, which can be pre-malignant, such as IPMN and MCN, which will require surgery as well. The benign one is only serous cyst adenoma, which doesn't need surgeries. When you talk about epidemiologies, pancreatic cancer is actually 14 most common cancers in Malaysia. And if you're talking about death, it is 11 deaths. So it jumped up 3 ranking because it is a lot of the time being diagnosed late, and also the disease itself is very difficult to treat because there's no very effective chemotherapy like what colon cancers has. The famous people who get pancreatic cancer, Steve Jobs, who got neuroendocrine pancreatic cancers, and Muhyiddin, our past prime ministers, also got pancreatic cancers as well. And if you look at our local data, UMMC data, so you can see that over the lower corner down here, most of the pancreatic cancers are actually diagnosed quite late. 53% of the almost 53% of them are diagnosed 50% of them are diagnosed at stage 4, and only a small amount of them are diagnosed at stage 1 and 2, and hence the prognosis is worse when you diagnose later, as you can see on the graph on the left-hand side here. And this is generally the similar in most of the Asian countries. And if you look at the median survival of study population is actually only 7 months, which is terrible. And 1, 3, 5 year survival is 30%, 8%, 3.7% respectively, and which also indicate that early diagnosis is one of the important points in managing pancreatic cancers. And unfortunately, these cancers are usually diagnosed very late. And when you talk about symptoms, most of them are asymptomatic and hence diagnosed quite late and poor prognosis. It can just present with abdominal bloat, just vague abdominal bloat, and typicals that we see is bloat, abdominal bloat, go to GPs and then subsequently give anti-gastric medication, not improving, and continue to give two and four until one day, then it is a bit too late. And depends on the locations of the pancreatic cancers. If it's situated at the head, sometimes it can present with obstructive symptoms, jaundice. It can obstruct the duodenum, causing nausea and vomitings, and sometimes can present as the back pain. When it is at the tail of the pancreas, it can grow until so big that you can feel an abdominal mass that and often at that time of diagnosis we will already have locally advanced or even metastasis. And non-specific symptoms like anorexia and loss of weight are typicals of all the cancers. In terms of investigation, CA199 is the tumor markers, and CEA, CA153, and CA125 can be raised in pancreatic cancers. And nowadays, with a lot of health screenings programs and BP lab and all this, I get a lot of referral of CA199s and hence, which is good that we pick up the pancreatic cancer early. And CT, good for staging. MRI is also good at looking at, especially you're looking at IPMN, where there's connection with the duct, and also PET scan to rule out metastasis. I routinely do PET scan if I'm planning a surgery for the patients, because we know that pancreatic cancer with a stage 4 disease, surgery is not going to help. So you shouldn't do surgery unless it responds to chemotherapy.
How
Endoscopy.
sensitive, sorry, can I stop you? How sensitive is this C19.9 CA?
It's
How
not.
sensitive? It's not, right?
It's not. It can be raised, but when it's markedly raised, then it raise an alarm. It doesn't. When there is a cancer, it might not be raised as well. So CA199 sometimes can be associated also with the poorer prognosis. So unfortunately, okay. The typical CA199 is raised, then you have to proceed on with the further investigations, CT scan or either CT scan or MRI. Okay, and nowadays when the patient diagnosed with pancreatic cancers, EUS become a very important, and this is an evolving kind of investigations. Because with the EUS, a lot of the time you need cytology, especially if it's locally advanced or it's a metastatic, you need a cytology to treat. Because for pancreatic cancer, it can still be rare forms such as lymphoma. And with EUS, you also can see whether it's communicating with the duct or not.
Okay,
Then
maybe
this
you
is the
can
IPNN.
explain what is EUS to some of us.
Sorry,
Yeah, it's okay.
endoscopy ultrasound.
So you actually put
endoscopy ultrasound, sorry, my apologies.
yeah, it's okay. I know what
You
it
put
is.
a inside with the ultrasound. Okay. So if you take a you aspirate and you send the fluid inside the cyst for CA, if it's raised, then it's mucinous cyst adenoma, which has a malignant potential, and in patients is supposed to go for surgery to prevent it before it turns into cancers. And if it's less than 5 nanogram per mil, then it's most likely a serous cyst adenoma, and that can be observed.
Oh, so when you do the EUS and you do a fine needle biopsy,
yep,
you actually check for CEA, the tumor marker.
Yes,
Oh,
you can take for CEA. Okay, this is one of the standard nowadays. And you can also send for amylase. If it's amylase, then it's very high, then it's a pseudocyst. And typically when it's pseudocyst, you take further history, then the patient have symptoms of acute pancreatitis before. Okay, so US also look at the morphology of the tumor. Likely malignant is in whether there's invasion, solid component. If there's ductal obstruction, it's more likely to be a cancer already. And portal vein and SME involvement is very important nowadays for a surgeon to decide whether which category of the cancer is, whether it's resectable, marginally resectable, or non-resectable. And also, of course, lymph node assessment. And treatment surgeries. If it's cancer, the only possible cure is surgery to excise it. And if it's pre-malignant like MPMN and NCN, you need surgery, preferably before it turns into cancer. Okay. And
can you go back to the previous slide, please?
sure.
Okay. Do all adeno-CA or this endocrine tumor start from this cystic neoplasm? Does it?
No, it can just develop by
Oh,
itself.
I see. Okay.
No, it doesn't. It doesn't.
It
So
doesn't.
adenocarcinoma can just develop by itself.
Okay.
Yeah, I think you're interested in this slide. Neuroendocrine tumor is slightly different. It's very rare. Neuroendocrine tumor is much less aggressive compared to adenocarcinoma. So for neuroendocrine tumor, even if it's metastatic, sometimes we will still go in and resect if we can take all of them. You take Steve Jobs, for example, he had neuroendocrine tumor. He went in, had dissection. He even went for transplant. I mean, a side story, he went for pancreatic transplant because he's so rich that he registered himself in every single state in UK and get the graph, the red graph early.
Oh, you mean he had neuroendocrine tumor, Steve
Yes,
Jobs, not
neuroendocrine pancreatic
adeno-CA.
cancer. Yeah, it's neuroendocrine pancreatic CA. But as you can see, despite the amount of money he has, the early treatment he has, he still succumbed to, but he managed to survive for quite a few years.
Yeah, quite a few years. But I
Yeah.
have a young lady, I met a young lady who also had neuroendocrine tumor and then had, I think she had more than one tumor. She has the
If they
MN.
are resectable, it's still recommended to resect all of them.
Yeah,
It
yeah,
does have
she's doing well.
survival benefit.
Yeah.
Yeah.
Okay.
Yep. Okay. So we move on. So what has changed over the years? You look at pancreatic cancers. Previously is almost a dead sentence. When you're talking about surgical resections with a mortality rate that was very high, but nowadays with a high volume center, mortality rate come down to less than 2%. And then when it's not resectable, of course, prognosis is poor. Then you go for chemotherapy. What has changed? What has evolved? There's this modality nowadays called borderline resectabilities. When we talk about borderline resectability, then this group of patients, the treatment is different, slightly different. And you go for neoadjuvant therapy, and it shows that it has large advantage in neoadjuvant therapy. So the surgeon is no longer the king that can just say that pancreatic cancers is belong to a surgeons for treatment, otherwise no one else can touch. But if you can see borderline resectability, there's 3 groups of them with vessel involvement, possible metastasis, and marginal performance status. All this is a multi-modality treatment in pancreatic cancer nowadays. It's no longer surgeons centered. So all this can be improved. You take, for example, possible metastasis, we send for oncologists to give chemotherapy first. If the query metastasis turn out to be not or respond to chemotherapy, then you go in for surgery. It has much better prognosis than you go in and just resect. And marginal performance, those especially those that you have weak, because a lot of the time you have loss of weight and loss of appetite, and then you should work together with your nutritionist to build them up and give chemotherapy during this period of time and make them fit enough for surgery before you do. So this is the multi-modality treatment that is evolving over the years to have better prognosis and better outcome. And when you're talking about resectable pancreatic CA, of course, you aim for RO resection. RO resection means completely clear with, this is only possible when you detect the cancer early, which is usually stage 1 and stage 2. And during the surgery, you're supposed to do adequate lymphadenectomy. This is also well documented. Nowadays, it is good in staging and reduce local recurrence. As soon as patients are confirmed diagnosed to have metastasis, you should not go in for surgery unless there is a mono mono metastasis, and also that is resectable at the same time, and in only if the patient has responded to chemotherapy.
Oh, I see. So mono metastasis means just one side or one
Yes.
nodule.
Yes. So if that is resectable, take for example, I've got a pancreatic patient with pancreatic cancer with single liver metastasis.
Yeah.
I wouldn't go in. I will send for chemotherapy, biopsy, send for chemotherapy. Chemotherapy shows that the tumor is well controlled, and also that the tumor in the liver lesion seems like it's responding and getting smaller. Then I'll go in and resect the primary and the liver metastasis. So this is because if it responds to chemotherapy, the chemotherapy is likely to be able to control all those micrometastases or kill all those micrometastases, and prognosis is better. Okay. So another thing is evolving is high volume versus low volume centers. High volume centers definitely have better result. This study has shown that whether you are, if you compare, you compare low volume centers and 0 to 10 cases to 10, more than 10 cases, it has advantage. 10 to 20 cases compared to over 20, it has advantage. Over 20 cases per year, it has advantage. So the higher the volume, the better. And it also has advantage in shorter hospital stays, and also low morbidity and cost effectiveness. So definitely a high volume centers. From the high volume center, usually for pancreatic cancers, we are talking about a center that is more than 20 cases per year. So in this study, actually, they define it as long as it is above 6 cases per year that the center is doing, it is still reasonable, but ideally it's more than 20 cases per year. So adequate lymphadenectomy back then, when 2008, when I was in Hong Kong for a year, they do extended lymphadenectomy. Nowadays, it's no longer needed. It has, take for example, on the red here, when you do a Whipple's procedure, you're supposed to clear all these lymph nodes to have prognosticated values. And when you do distal pancreatectomy, all this group of lymph nodes are supposed to be clear. There's no advantage in extended. So at that time, when I was in Hong Kong, at that time, this paper was not out yet, and hence we were doing a lot of extended lymphadenectomy. And role of lymphadenectomy is, of course, again, prognosticated, and you're supposed to clear more than 15 lymph nodes in your histological slides for both pancreatic duodenectomy and distal pancreatectomy. But unfortunately, despite these are my clearance, you can see that is all the new portal vein, SMV, hepatic artery, IVC down there. Unfortunately, it's very difficult to find a hardworking pathologist to go and slowly look at 15 lymph nodes. And these are my distal pancreatectomy. You can see all the vessels are denuded. You can even see renal veins, SMA, and also kidney. So sometimes I still find it difficult practicing here to keep up with the world standards in that sense. Okay, so
do you pick out everything then?
Yes, I pick up everything. You look at this, is like usually these are covered with fats and lymph nodes and everything. So these vessels are all denuded. These are for, if in case there's any medical student now here, this is SMV, portal vein, common hepatic artery, right hepatic artery, left hepatic artery. This is IVC, right renal vein, left renal vein, left renal vein, and SMA is right behind here. So these are standard lymphadenectomy you're supposed to clear. If you still see any tissue around it, you're not doing a good job. Okay. So the lymphadenectomy, I find personally no scientific proven that if you do adequate lymphadenectomy, if the recurrence come back, at least it's metastasis, it's not local recurrence. If you don't clear all this, when the lymph nodes come back, it get bigger. Patients have a lot of symptoms. They get obstructive symptoms, jaundice, unable to eat, that kind of thing. So I standardly clear all the lymph nodes around that area. So when we are talking about borderline resectability, what are the evidence? Blake Caddy, this is a prominent oncologist. Unfortunately, he passed away 23 last year. He said biology is the king. Selections of case is queen. And the technical details of surgical procedure are prince and princess that of the realm who frequently try to overthrow the powerful force of the king and queen, usually to no long avail, although with some temporary apparent. This will summarize today's lectures. So the most important thing is the biology of the tissue. In fact, not only in pancreatic cancers, in all the cancers. If your cancer doesn't respond to chemotherapy, you have very bad prognosis. You can do whatever you want to do. So what we can do is make sure that we select the case properly, which one go for therapy first, chemotherapy first, which one go for surgery. And of course, if the patient go for surgery, good surgery and good surgeon play a good role in terms of lower the complication rate and make sure that you do proper clearance.
So this CA pancreas, right? When you give, let's say, a trial of chemotherapy before surgery, as we all know, or as we all understand, CA pancreas have a very short term, 7 months, you said that some people live. So how
Yeah.
long do we wait?
So it usually will give my good questions. My subsequent slides will answer your questions.
Okay, fine. Okay, thank
Maybe
you.
I proceed
Okay,
first.
sorry.
Okay.
I always
So,
okay. Okay.
good to have attentive audience.
Moderator, you mean?
Moderator, sorry. As you can see, this is a landmark study. This study shows that there is the question that you asked is very valid, because if you look at the study down here, you can see that they group what I've just mentioned. So group A is those that with borderline resectable, whether query vessels is involved. Group B is query suspicious of metastasis but not confirmed metastasis. Group C is those that is weak and malnutritious and not good performance to go through the surgery, query good performance to go through surgery. You can see that if they subject them to neoadjuvant therapy, the survival is much better. Okay, but on a cause of the resectability rate, those who went under surgery is lower. So sometimes it's very difficult to explain this concept to patients, because some of them wouldn't respond to chemotherapy after the surgery and come back, and or neoadjuvant therapy, they don't respond and eventually progress. And in fact, this group of patients, you have to tell them in advance, if it comes back like that, in fact, if I go in for surgery and resect it, it will come back in other places also. So a lot of the time, it takes another 10-15 minutes to explain to patients what do I mean by borderline resectability. So, and this is a meta-analysis. So this is class 1 evidence, especially you look at there's 39 studies, including 3 RCT. So this is a good evidence study. You can see that the median survival with neoadjuvant therapy is actually better. And the resection rate, you can see, as I mentioned, is lower because some of them do progress and become non-resectable. Even at that time, is borderline resectability. And our resection is higher. So nodal is negative because you give chemotherapy, a lot of the times they have already respond to chemotherapy. And the most important thing, of course, median survival rate is much better compared to this.
Oh, this is quite difficult. Okay, let me get this. So if you do neoadjuvant therapy, okay, because you wait, there are chances that your resection rate then becomes lower. Obviously, from here it's lower, because there are some patients who will not actually respond to neoadjuvant. But those who respond to this neoadjuvant do better because you have total resection. Your nodes involvement is less, and your survival rate is a lot more. I mean, a lot more to 15% to 15 months lah.
Yes, I was attached to Hong Kong Queen Mary Hospital for a year. At that time we do a lot of very aggressive surgeries. We do portal vein resections, SMV resection, and joint back. And when I come back in 2009, I did the same thing as well. But you'll find that a lot of the times they will come back with metastasis. After, well, you can take it out. You feel good, you can take out, or even vessels you can take out. But a lot of the time that patient will come in with metastasis. In fact, if you have confirmed tissue diagnosis of portal vein involvement of the tumor, the survival rate of 3-year survival rate is actually 0. So why go in and do the resections if the survival rate is poor? So you have to keep that in mind. What we, as doctors, we have to, first thing is do no harm. So in fact, you are doing more harm. So this is an evolving concept in treating of pancreatic cancer, to the extent that slowly there are studies showing that some patients, especially the elderly, maybe without surgery, just go for chemotherapy, the survival are equivalent to surgery. But there is weak evidence, it's not a strong evidence. So the borderline resectability, SMA involvement, SMB involvement, query involvement, and borderline performance, all this go for neoadjuvant chemotherapy. I will say that is almost unethical if you already know that and then you do surgery on this patient, because the evidence is quite strong nowadays. Okay, this is evolving. Multi-modality treatment is very, very important. So nowadays, oncologists are our very good friend.
Let me just, the SMV and SMA stands for superior mesenteric. Okay,
Sorry,
I got
superior
it.
mesenteric vein and superior mesenteric artery.
Okay, I got it right.
Sorry.
Okay, it's okay.
So I'm too used to giving talks to surgeons.
Yeah. Okay, let's go on.
Okay, this is a metastatic. Like I mentioned whether there's any use in going in for surgery. So if it's mono, if you can resect it, slightly better, but it's still not very good. And when you're talking about metastatic, this is talking about synchronous tumor. When you're talking about metachronous, it also depends on the differentiations and also depends on the metastasis come how far after the initial primary cancer surgery. So this apply not only to pancreatic cancer, you're talking about breast, colorectal cancers. If you have a cancer resected and you come back with a liver mass, there's a difference if you come back 6 months after it or 5 years after it. So of course, the 5 years after your resection, it has a better prognosis and still worth going in for surgery. Okay, so another thing that is evolving is chemotherapy. Chemotherapies, and back then when I was in medical school or even postgraduate studies, is always gemcitabine. But nowadays, this is landmark study saying that if you give gemcitabine, the response is a blue one. If you give nab-paclitaxel, it's yellow. But if you give together, it has a synergistic or additional effects, and hence nowadays it is always a combination therapy. As you can see that over here, there is gemcitabine alone and combination therapy. Another good regime is FOLFIRINOX, and FOLFIRINOX actually have better survival compared to gemcitabine, but it also has quite a significant side effect, unfortunately. But in this study, it only shows that it is slightly higher side effect in FOLFIRINOX, but because there's one toxic death in the gemcitabine arm, so it becomes statistically not significant. But we do know that FOLFIRINOX do have some side effect, especially in terms of neutropenia, sepsis. Okay, so you can see that it has much better survival rate, overall survival and disease-free survival rate compared to gemcitabine. So since then, a lot of studies, meta-analysis compared to whether it's locally advanced, then you'll say FOLFIRINOX has better response, and neoadjuvant FOLFIRINOX has better response than gemcitabine, similar side effect, metastatic cancer, similar effectiveness, different side effect. Generally, if the patient is fit and young, nowadays oncologists most of the time will give FOLFIRINOX because they can tolerate the side effect. If it's slightly older, they might be slightly more gentle, go for GemNab. And precision medicine, precision medicine, we're talking about targeted therapy, immunotherapy. There is plenty of them. I pity the medical student nowadays. Last time, pancreatic cancer topics, gemcitabine. Nowadays, they have to know all this immunotherapy, targeted therapy, Avastin, and all these things. So a lot of studies are going on. Watch out for this space, and in the futures, then hopefully they will strike a goal in treatment. Then surgical treatment, as a surgeon, my passion is surgeries, and hence surgical treatments is something that I like to talk about. And as you know, pancreatic head, then you will do Whipple, pancreatic tail, you do a distal pancreatectomy. How about minimal invasive? Nowadays, a lot of people talk about minimally invasive surgery, but not like other surgery. Pancreatic surgery is actually a very demanding surgery. Especially we're talking about Whipples, it's technically challenging. Minimally invasive surgery has an advantage of shorter hospital stays, less painful, and lower blood loss. How about surgical outcome and oncological outcome? Are they equivalent or are they good? So about distal pancreatectomy, these are the three important study, Leopold, LEPOP, and diploma study, which I summarized in this table for you. And you can see that it has a functional recovery advantage. It has shorter hospital stays, but the overall operative time can be higher in minimally invasive surgery. Blood loss is of course less, and there's some cost effectiveness as well in minimally invasive surgeries. And this is the minimally invasive surgeries that I do for distal pancreatectomy as compared to standard surgery, open surgery. A rooftop procedure is very painful, and patients a lot of the time will have longer hospital stays by at least 2 or 3 days. Whereas this is the technique I developed, only 3 pores, and the scar is minimal, and patient usually can discharge very early. And
Wow.
and
This is a Whipple, is it?
no, this is distal pancreatectomy.
Oh, so, okay. So it's not a
Yeah.
Whipple. Okay.
Okay, so when you talk about minimal distal pancreatectomy, nowadays we are talking about RAMs, which we clear all the lymph nodes, and you can see that it can be done quite easily as long as the tumor is not very big. I think this procedure should be a standard of care. And you can see that surgery, Venkas say that lower blood loss, shorter hospital stay, lower complication, and no significant increase. And you can see on here, you can see the pancreas down there trying to feed the pancreas. And when Hills say that lower blood loss, low and shorter hospital stay actually has higher RO rates. And this, you can see that I'm taking the spinning artery down there. And but it has lower genital resection and lesser lymph node retrieval. So you have to be very careful of what you're doing, and make sure that you clear all the lymph nodes. But minimally invasive surgery compared to open surgery has similar survival. This is the superior mesenteric vein, or this is the neck of the pancreas that you can clear. And I think to save times, I think we'll proceed, and you can see that this is the
we have time, don't worry.
splenic vein. And then clipping spinning, I'm supposed to clip the artery before the vein, and this is then went back to clip the artery, and then subsequently vein. Okay, and it is a methods of training and practice that it can be done quite easily. As you can see that it can be done with only 3 pores, and then subsequently then you feed the artery. This is a lymph node clearance around the celiac axis that you can see that the lymph nodes, you're supposed to denude this lymph nodes and make sure that you send all the lymph nodes. And when eventually what you are trying to get to is the end result, which is, sorry, this thing is coming in, which is a clean surgery. Okay, you can see that SMA, celiac all clear. You can see SMA, you can see renal vein down here. This is adrenal gland and clear, totally clear. And so how about Whipple? This is a Whipples. Okay, Whipples, you can do either rooftop incision. For me, I usually do this upper midline incision, much smaller and much less painful. Midline rooftop incision actually cut through muscles and it's very painful. So if you do laparoscopic, is those yellow dots. If you do robotic, it's the red dots. It's just different port placements. And if you look at the laparoscopic Whipples compared to open Whipples, again, there is advantage of length of stays, but it takes longer operative times and it has lower blood loss, but have to be very careful. There's one study, Leopard 2 study, actually has high mortality, and this study actually end premature. So whoever want to embark into lap pancreatic Whipple surgery, you have to be very careful and make sure that you choose the case, select the case properly. And this study shows that lap versus robotic, as lap has higher conversion rates and also has higher 90 mortalities in robotics. And
How come?
in order to,
Okay, sorry, lab and robotic use the fairly same method, right? They use also keyhole, right?
Yep. There's different advantage. I'll come to it.
Okay.
I'll come to it. You ask all the essential questions. Very good.
Of course. Okay, go.
So as you can see, first things for those who are interested in developing laparoscopic surgery, this is the first thing that you should do. Actually, even this on top is open surgery, below is laparoscopic surgery. Before you embark on laparoscopic surgery, you have to practice your skill in open surgery. So even in open surgery, before I embark that, I already use laparoscopic equipment in order for me to safely embark on laparoscopic surgery.
I see.
You see,
Okay.
it's very similar, and
Okay.
I use a laparoscopic type of harmonic scalpels to clear in before even embark into the laparoscopic surgery. The challenging part of laparoscopic or minimally invasive surgery is actually, especially for Whipple, is the anastomosis. And I will show you the anastomosis. Okay, you can see that to join this, you can see that all these are 6O proline sutures which are thinner than your hair. So to stitch and tie is very, very challenging using laparoscopic surgery. And robotic surgery has this advantage because the arm can be bent at the angle. I will show you some video of robotic surgery. You look at this laparoscopic surgery at the bottom with the anastomosis, you can see that I can stitch, but not as elegant as robotic surgeries. Okay, so we move on to robotic surgeries versus lab. So robotic surgeries in the hands of experienced surgeons may has modest yet statistically significant reduction in estimated blood loss, post-operative stay, wound complication, and delay gastric emptying compared to open surgery in the hand of experienced surgeons. So robotic surgery at the moment still is limited practice to experienced surgeons. And when you look at that in terms of treatment index, it has lower 30 days mortality, but it does have a lower RO resection in this study. So it at the moment is still under studies, but it is promising, to be frank. So this is the robotic surgery, how I do my robotic surgery. You can see that I sit on the console. This is the surgeon there, and your assistant is sitting there, and someone else can watch it whenever they want. This is pancreatic cancer, pancreatic carcinoma that I excised, I've done choledochosis and pancreatic cystic tumor as well. And let me show you a video of robotic surgeries. As you can see that compared to laparoscopic, you can see that the robotic arm, you can curve here and there. So dexterity is much better, but unfortunately the harmonic ACE, the energy device, which cut and seal at the same time, doesn't have the wrist functions. And
The
but
wrist means your wrist lah, means the movement
yes,
of
you
your
can
wrist.
turn. I show you the part that I anasmose. You see, both of them is like your hand, your extension of your hand, that both of them can turn and twist at any angle. So you can see that is much nicer surgery compared to laparoscopic. So robotic surgery, if you ask me, it has advantage in anastomosis. In terms of dissections, I think laparoscopic can do quite well as well. Of course, I prefer a robot. And in fact, the reason I joined Sunway is actually because of the robot. Okay. Because I've been waiting for UM to buy a robot for 10 years and they don't buy it. This is the I feel that it has potential futures of the surgery. So hence I joined Sunway for this reason. So that is robotic surgeries. And another evolving part in pancreatic surgery, not only pancreatic surgery, all surgery is the ERAS protocol, enhanced recovery surgery after surgery. So these guys develop pre-op preparations, intra-op techniques, and also post-op early nutrition, early ambulations, early catheter removal, all this. They no longer want to keep the patient for long to be safe. You see, even before operation, we do carbohydrate load. Although at the moment, I've not embarked into this. And other than that, all this I've been following the practice. And it shows that it has advantage whether it's open or robotic surgeries, that it has advantage in terms of cost and length of stays. And you take, for example, this is a case that I recently do quite a significant size tumor, 3.8 centimeters, 61 years old, no vascular involvement, and hence you do open surgery, and HPE show well differentiated. And you look at, if you apply ERAS protocol, this show the tumor here dark dilated because of obstructions. In fact, if you look at previously pancreatic surgery, Whipple procedures, a lot of the time patient will stay in for 14 days, 2 weeks and above. But with this enhanced recovery, you can see that previously we were worried because pancreatic, you eat, then you stimulate pancreatic juice, you're worried about leak, but no longer. You say, these patients, for example, first day I give clear fluid already. Second day, nutrition, nourishing fluid. Third day, soft diet. And fourth day, normal diet. We no longer drag. As long as there is no drain bilirubin and amylase show no leak, quickly progress to food. And you see physio first day, big surgery, huge surgery, physio get the patient out of the bed already. And early drain removal, and you can see patient discharge half of the times and discharge on the 1 week after the surgery, major surgeries. So in summary, it is evolving. Pancreatic cancer, it does carry poor prognosis, and surgical resection is only chance of cure. And neoadjuvant therapy followed by surgery actually improve borderline resectable. So nowadays, as soon as I see a borderline resectable pancreatic cancer, I send to oncologist. I no longer go in for surgery. FOLFIRINOX or GEM NAPCAP is the choice of neoadjuvant, adjuvant, or palliative chemotherapy. MIS has advantage in shorter hospital stay and less blood loss. However, it should be practiced in specialized center. And in fact, this fellow actually summarized everything. Biology is a king. You appropriate chemotherapy in the appropriate times. If you give neoadjuvant chemotherapy or targeted therapy when it's borderline resectable, select the case is a queen. You don't go in when you see that it's borderline resectability. You don't go in if vessel involvement and technical details or surgical procedure are prince and princess. That is our role as a surgeons. You have to improve on your technical details and hints to ensure better outcome in terms of the surgery, less complication, less mortality. This is Western philosophy. This philosophy has been in ancients. You once know his own strength that and of that of the enemy is invincible in the battle. Every time you go in a surgery, it's a battle. 自己百战百胜. You want to win the battle, you know the cancer, whether it responds to chemotherapy or not, pass it out first before you go in for the surgery. And if you cannot win the battle, it's better to retreat. 走为上计 because you might harm the patients. You look at, you see a cancer that involves vessels, you go in, patients might develop complications. Once a patient involve complications, then patient will not be able to go through chemotherapy at all. And worse still, patient might die. With that, I thank you for your attention.
Thank you very much. It's very interesting. Not that I know much about pancreatic CA, and not that I know much about robotic or even but I learned a lot. So we have a question from Doquity. We actually have two. Dr. Muhammad Amir asked, if let's say a patient in the 50s does a routine annual checkup and turn out CA 19.9 is raised, do we refer this patient for further checkup like CT scan? Is there
Yes,
a cutoff point?
I will say that it also depends on how raised it is. We know that the normal range is fit into 95% of the populations. There's 5% that can be slightly out of reach. If it's very raised, let's say it's in the hundreds and thousands, there's definitely something wrong. Okay, but CA199, bear in mind that sometimes it can be raised in certain situations, even with AGE sometimes can cause CA199 raise. You get hepatitis, you also get CA199 raise. You get biliary obstruction, also get CA199 raise. But also bear in mind that CA199 raise can be lung CA also can sometimes cause CA199, and of course you're talking about ovarian and testicular. So in the current days, if you have raised CA199, if you don't investigate further, you are open to litigations if you miss something.
Yes.
So it's better to send that for further investigation. If you do further investigation I will usually recommend either for CT-TAP or you do a MRI. Okay. So if there's nothing, then you have done your duties in finding. So typically, if it's nothing, I will say repeat in 3 months' time. If it stay the same, then it's okay. Just follow up with another CA199 in 6 months. If it is coming down, of course, you are not worried anymore. If it's continue to go up, you go for another CT scan or MRI, because sometimes the tumor can be so small that it cannot be picked up by CT scan or MRI. So you definitely have to investigate and have to follow up.
I think it's a good practice to investigate further because I practice a lot in Beacon and I've seen a lot of cancer that was dismissed, okay, by the GP or by not by the patients, by the doctors themselves, because either they were ignorant, couldn't care less. So I think that it is proper to get it investigated, because the investigation doesn't mean that it's invasive. It doesn't mean that there is a bad outcome. But if the outcome is not good, you can always treat it early. Question number 2 by Dr. Ayn asked, is there any scoring for early screening or diagnosis of pancreatic CA?
I would say not really, because just go back to just now that question, CA199, if it's raised, you have to further investigate. But a lot of the times, I do understand that CT scan and MRI, all these cost money and some of them cannot afford. But you have to give the patient the options. You can repeat it in 2-3 months times, or you go for the further investigation. Now come to your new questions. When you talk about screening, you have to have a prevalence of the disease of very high. So pancreatic CA is not high enough like colon cancers or gastric cancer in Japan. So there is no screening per se. The most screening is done is the tumor marker only. So there's no specific target group of.
But I guess maybe sometimes when part of the package is an ultrasound abdomen.
Yep.
I have seen complex cysts being detected before, but not
Yes.
so much of CA pancreas, like, to be honest, but complex
Yeah.
quite common.
Possible. I mean, screening ultrasound is actually depends on how you view it. Ultrasound is cheap and there's no radiations. Only thing that is very operator dependent, and also pancreas is retroperitoneal organ. Sometimes the colon and stomach can become to the front and you cannot see the pancreas. So in terms of screening, you're talking about pancreatic cancers is usually CA 199 or CEA. Okay, so it depends on your screening package whether it come with a tumor marker or not. I tend to see quite a number of referral of for CA199, and to be frank, a lot of the times you won't find anything, but occasionally you detect some pancreatic cancer, which is good because it detect early, and hence patient can go for curative resections.
Okay, Dr. Zhu, I don't know how to pronounce his name. Other than the difference in the arm of the robots versus laparoscopic surgery, do surgeons also present in robot? Of course, surgeons are present in robotic surgery.
Yeah, of course, surgeon is present. Actually, you are
You show the
controlling the
slide
arm.
again where you're sitting on the
Yeah.
chair.
Yeah, you're controlling you're actually the one that is controlling the robot.
Surgeon is controlling the whole
Yeah. So
whole
you look at this console, I actually have two things down here on my arms controlling whether open is like a crab claw like that, open and close, and I can twist around, and the arm in the robot actually move according to what I move. So it's a very it's quite technical, challenging audio as well. So even before I sit on this console on the patients, I've gone through
Are you sharing?
hours of training. Am I sharing? Sorry.
No, we don't see
Sorry,
it.
I've not shared this. Okay, so let me share.
Yeah.
So
Sure. It's quite interesting. I mean, I always hear them talk about robotic surgery. So
so
it is a valid question, but yes,
yeah.
of course, a
So you
surgeon.
can see that I'm sitting down here with my arms. There's a claw thing down here that I put my finger in, and I control with 3-finger control. I can zoom. I can control the camera to zoom in and out at
No,
and
show
different.
where the patient is. The patient
The
is where the
patients
nurses
is
are.
here,
Yeah.
behind here. You see the nurses is there, patients is there.
Have
So
you ever had to convert a robotic surgery to an open surgery?
yes, in fact, I just did one. You have to know, like I mentioned just now, you have to know your capability. Robotic surgeries, if you want to dissect vessel, is when the tumor invade into vessels, it can be very challenging and can be a bit risky. So today I did have a robotic surgery convert to open, and in fact I just came back home. Pre-op, it was US, and CT scan doesn't have any vessel involvement. Unfortunately, patients cancel his own surgery and delay her own surgery to 2 weeks later. And by the time I went in today, the vessel was involved. So I stopped
Just
it there.
2 weeks, huh?
Yeah, I stop it there and convert to open surgery, because like I mentioned before, sometimes retreat is the best strategies. You don't go ahead and sometimes you harm. True enough, when I went in for surgery, the surgery is difficult. I managed to take out the tumor, but it did bleed. Should I have done it using the robot, it probably had bleed even more and eventually have to convert anyway. So you have to know your limit, the limit of the robots, and then do it safely. Safety is always the main priority in all the surgery.
In
Okay.
any way you treat the patient. Okay, question number 4. Is neoadjuvant chemotherapy recommended for borderline resectable cancer? What about pancreas NET means what? Neuroendocrine tumor.
Neuroendocrine cancer. Okay. neuroendocrine cancer usually, if it is resectable, you just go in and resect it. Okay, because it actually carry much better prognosis compared to your ductal adenocarcinoma. So for neuroendocrine tumor, let's say a patient come in, we say, I just saw a patient last week only referred by Alex and our endocrinologist. Multiple 3 spots of cancers in pancreas, 1 spot in mediastinum, and then also queries in bone mets. And this kind of patients, we still consider surgery because we know that this has a slightly benign cause. And neuroendocrine tumor doesn't respond to chemotherapy that well also. And you can try hormonotherapy, sandostatin LA, which can control the symptoms very well. But this patient is very young. The one that I mentioned is 40 years old. Then he's a mechanics, and because of the it's most likely a secretory tumor that probably secrete insulin, and because of the secretory property, sometimes he went into blank because of hypoglycemia. So it become dangerous and affecting his livelihood. So we are discussing whether we should go into surgery. And again, we are going into MDT discussion next week, whether it will help these patients if you go for aggressive surgery. Nowadays, most of the major big hospitals should have MDT discussion. You cannot be snobbish enough to think that you know everything, because you cannot possibly learn everything. So we pick the brain of oncologists, we pick the brain of endocrinologists, we pick the brain of the radiologists in the MDT to tailor a treatment for patients in MDT.
Okay, what about Lenovo? De novo or Lenovo? De novo. Lenovo. What's Lenovo metastatic pancreatic and ET? Is it Lenovo? Lenovo is a brand of a computer, I think. I think
I don't know how to answer the
I
question.
don't know what's the question. Maybe
Okay.
it's de novo. De
Uh-huh.
novo metastatic. De novo means not touched lah, basically. Means not operated on, maybe. I'm not sure. I think we'll leave this.
Well, if the patient is not fit for surgery at all, you can use sandostatin LA to control the symptoms sometimes. Okay, so sometimes the symptoms still can be controlled, but majority of the time when you come to neuroendocrine tumor, the recommendation is if you can take out everything, take it out. Except that if it's multiple metastases that you cannot take out.
Yeah, okay. So if it's de novo metastatic, so de novo is correct lah. I'm correct that it says de novo. So de novo means that it's like naive lah, not touched lah. But if it's multiple sites of metastasis, I think you wouldn't touch either, right?
It's open for discussions. It's open for discussions. So it's whether you can take them all out without causing too much harm, too much debilitating problem to the patients. Okay. It's always in this kind of situation, it's always you have to weigh the risk against the benefit. If the benefit outweigh the risk, then go ahead. If the
For example, renal cell CA, once you take out the primary, you do the nephrectomy, sometimes the secondaries can also shrink in size or completely disappear. So I hear.
Oh, okay. I'm not well versed in RCC.
Yeah, that's right. But okay, I think we did well. We finished at 10. And I'm going to stop recording. Okay, before I stop recording, so I've shared I've stopped